Okay, so I'm going to go over the indications of the patient for the central venous catheter placement, volume resuscitation, and needing to infuse vasoactive medications, and if we needed to use it for CVP monitoring. Obtain informed consent after I explain the risk and benefits of the procedure. I'm going to do a site selection in holding. I want to look at right and left IJ, preferably right because of the anatomic structures on the left side of the neck, thoracic duct, and it's more direct access on the right side to the right atrium. So we're going to go to the right side. There's no sign of infection. There's no redness or swelling, so I think we'll be good for that. Going to bring the patient back to the OR. I'm going to make sure my monitors are present, my resuscitation airway equipment is present. I'm going to identify my landmarks. So I've got my sternocleidomastoid, I've got my sternal head, my clavicular head, my clavicle running horizontally, my cricoid cartilage, which I'll use as a landmark, ipsilateral nipple as my target, and I feel for a carotid pulse, making sure I know kind of where to find it when I go to place the line. And I've got a strong one, so we're good for that too. I'm going to position the patient. We're going to do supine, obviously, slight Trendelenburg, slight head down so I get good venous engorgement. I'm going to have their head turned away from the insertion site to the left, and I'm going to remove the pillow if need be, just so I can get good access to the site. Alright, so I will have induced the patient, so they're asleep, and I'm going to go ahead and proceed with my procedure. Going to open my central line kit. And prep the patient. So I'm going to make a triangle between the insertion site, the sternum, ipsilateral nipple, kind of in a triangle. Kind of get that good and clean. Let that sit, air dry. While I'm letting that dry, I'm going to throw this away. Letting that dry, I'm going to continue opening my kit. I will have gotten a bio patch beforehand and a tegaderm for at the end when I'm ready to dress my line. Alright, now I'm going to don my sterile gloves and my gown. I'm going to throw my dirty gloves away. I'm going to go ahead and open up my sterile gloves so they're ready to go. Okay. I'm going to let this fall. I'm not turning my back to my sterile field. I'm going to go in to help me tie up my gown. I'll go ahead and put on my sterile gloves, cuff to cuff, thumb to thumb. Go ahead and drape my patient. That head. And go ahead and re-identify my landmarks. I've still got my sternal head, sternocleidomastoid muscle, and my clavicular head, my clavicle. Go ahead and reassess for a pulse, make sure I'm in the right spot. Okay, and I seem to be good. Go ahead and dab off this site. It's gonna go in the trash. I'm going to go ahead and get my supplies together. My guide wire ready to go. Go ahead and take all my caps off. I'm using the finder needle technique. Got that ready to go. Go ahead and uncap my scalpel. Have my dilator. Check my catheter. Check the tip, make sure it's intact. I'm going to unclamp my distal port. Make sure the other two are clamped still. You're good to go for that. Okay. I'm going to use my finder needle. I'm going to feel for the pulse again. I'm going to go at a 45-degree angle, aiming towards the ipsilateral nipple, bevel up. I'm going to be aspirating as I insert my finder needle. Alright, we've got dark red blood, and it's continuing to come. That's my first sign of venous access, is that it's dark red. I'm going to hold this in place and get my catheter needle. We go on the same trajectory, bevel up, aiming towards the ipsilateral nipple. I'm going to place this. Aspirating on insertion, looking for dark red blood. And I've got return. So I'm going to hold on to my catheter needle, remove my finder needle. I'm going to aspirate again to make sure I'm still in place. And I am. Going to advance my catheter without my needle. Remove my needle, hold my finger over. I'm going to look for pulsating blood as another technique of confirming that I'm not venous, or that I'm not arterial, that I am venous. I'm going to use my guide wire and the Seldinger technique to advance it. 12 to 15 centimeters. Watching my EKG tracing, looking for dysrhythmias. Okay. I'm going to hold my guide wire in place while removing my catheter. Alright, hold that stable. I'm going to use my scalpel to do a skin nick away from the guide wire. Alright, I'm going to use my dilator. Make a little tunnel to make it easier for my central venous catheter. I'm going to feel for the pop of the platysma. And I'm going to insert my catheter. What I'm going to be doing on insertion is looking for the guide wire to exit the distal port. I'm going to be drawing the guide wire until I see it exit. I see it coming. All right, I'm going to hold this as I insert my catheter. rest of the way out. Okay. So I'm going to aspirate and flush my ports. Making sure I still have dark blood coming back. I'm going to clamp them off. Then I'll get a syringe full of LR for my fluids to flush them all back through. Okay, we're good to go for that. I'm going to go ahead and suture my line. I'm going to go ahead and hook it up to my pressure tubing and transduce it. Looking at my final technique of confirming placement. And I'm going to apply my BioPatch. Have that on. I'm going to remove my drape, holding my line in place. So then I can apply my Tegaderm and secure my line and proceed with the case.